Okay, as you can see here, oxygen saturation in normal range using the lowest necessary oxygen flow. We keep discussing this, and you're going to see this, and it's going to be reinforced in the uh, escalating airway algorithm videos that are on here. We always want to let the patient um, take care of themselves in the uh, with the least amount of help as possible. We don't want to go overboard. We don't want to overtreat to the extent that it's harmful. So as we go, we're talking about oxygenation, so we're going to talk about oxygen supply and regulation. So oxygen is supplied in either a compressed gas or a liquid. Compressed gaseous oxygen is stored in an aluminum or steel tank, and they come in multiple sizes. We have the 400 liter D tank, we have the 660 liter E tank, or the 3450 liter M tank, and those are the volumes of oxygen that those particular tanks hold. That's going to be important. I would write that down. To calculate how long the oxygen will last, use the appropriate formula. The same formula, but with different constant for each cylinder. 0.16 for a D cylinder, 0.28 for an E, and 1.56 for an M. So our oxygen supply formula, the D cylinder tank life in minutes would be the tank pressure in PSI, which is on our gauge, times 0.16 divided by the flow rate you choose, or your liters per minute. So that again is tank pressure in PSI multiplied by 0.16 divided by liters per minute. The same would be for the E cylinder, except your tank pressure times 0.28 divided by liters per minute. And the M cylinder would be your pressure times 1.56 divided by liters per minute. Now, those are your gaseous oxygen storage that's most common. There are a few ambulance services out there that on their ambulances they are using liquid oxygen storage systems, and those are a little bit different. So liquid oxygen is cooled to an aqueous form or to a liquid form and warmed back up to its gaseous state for delivery. Although liquid oxygen requires less storage space than an equal amount of compressed gas, you must keep it upright and accommodate other special requirements for its storage and transfer. The regulator for an oxygen tank is either a high pressure regulator, which is used to transfer oxygen at high pressures from tank to tank, or a therapy regulator, which is what most of us deal with, which is used for delivering oxygen to patients. The default pressure for therapy regulators is 50 psi, which is controlled within the regulator to allow for adjustable low flow oxygen delivery, which is your 2 to 25 liters per minute, depending on your regulator. So our oxygen delivery is measures in liters of flow per minute. So a number of delivery devices are available, and we're familiar with most of these. The patient's condition will dictate the method you use and the delivery device that you use. You must continually reassess the patient who requires oxygen therapy to be certain that the method of delivery and flow rate are adequate. So if you throw a patient on 2 liters per nasal cannula and you started out at 88% SaO2, then, and that only bumps up to 90 from 88 to 90 on 2 liters, you may need to either bump that up to 4 or 6, or you may need to switch to a simple face mask, but you need to judge your patient and give that opportunity to work. But that falls back on your reassessment skills or your reassessment routine. Some patients require positive pressure ventilation rather than passive delivery device. So if your patient is breathing 6 times a minute, and our normal and our goal is to 8 to 10 breaths per minute or 10 to 12 breaths per minute, and they're breathing at 6. So we're going to have to add an extra 6 breaths in there in between the other two. So they need positive pressure ventilation, and they may need positive pressure assistance on the 6 breaths that they take by themselves. They may not be deep enough to allow for proper oxygenation as well. So these are all things that you need to consider. So as we talk about the delivery devices, let's start with the most basic, which is your nasal cannula. The cannula is a catheter that's placed in the nares. It's got the 2 prongs. Some people call them nasal prongs. There's multiple names for them. The official name is nasal cannula. And they will provide an optimal oxygen supplementation or an oxygen delivery of up to 40% when set at 6 liters per minute. Now, anybody that's had 6 liters per minute blowing in their nose knows that it is not comfortable, and it will dry you out pretty quickly. So I wouldn't want to leave a higher flow rate nasal cannula in for any longer than you absolutely have to. But if they won't tolerate moving up to a simple face mask, or you don't have a simple face mask and they won't tolerate a non-rebreather or a partial rebreather, they may just have to suffer through the nasal cannula for a little bit. But just be aware that dries out the nares pretty quickly, and easily break down and develop bloody nose and such like that, which creates yet another problem. Patients generally tolerate the nasal cannula pretty well, and it's indicated for low to moderate oxygen requirements and long-term oxygen therapy. So these are your COPDers or your CHF, whatever, that they need that supplemental oxygen, but they don't need a lot. So this works pretty well. The Venturi mask you don't see in the ambulance or the pre-hospital setting near as much, but they do show their faces around, and mostly in the hospital, and mostly respiratory therapy uses them. The Venturi mask is a high-flow face mask that uses a Venturi system to deliver a relatively precise oxygen concentration, regardless of the rate and depth of breathing of the patient's breathing. As oxygen passes into the mask through a jet orifice at the base of the mask, it entrains room air, meaning it blends in, it's pulling in room air with it through the Venturi and mixing, and then delivers the resulting mixture to the patient. Some Venturi masks have a dial selector to control the amount of ambient air taking in. Others have interchangeable caps. Either type can deliver up to 24%, 28%, 35%, or 40% oxygen, depending on which piece you're using. The liter flow depends on the oxygen concentration desired. So not only are you using the caps, but you're also using your flow to control your percentage. The Venturi mask is particularly useful for COPD patients, where you really kind of want to control the inspired oxygen concentration. Again, this is usually hospital and ER stuff, and respiratory therapists that do this all day long, every day, are generally the ones who use this more. If you have it on your ambulances, I'd follow your protocols as to the use and your percentages. Otherwise, it's going to fall back on your education and experience and your assessment skills on what's going to work best for your patient. You may encounter these during transfers. That may be another place that you see these going from hospital to hospital. We're not going to watch this because we all have seen a bag valve mask and an oxygen tank being used. We'll review that in class. We know how to apply a nasal cannula. So let's get back to our adjuncts. So a simple face mask is indicated for patients requiring moderate oxygen concentrations. The side ports allow room air to enter the mask and dilute the oxygen concentration during inspiration. So the simple face mask is the same as our non-rebreather masks, except where the non-rebreathers have the little flutter valves on the up on the air exhaust ports, or where the patient would exhale. There are no valves there. There's just the holes. So, and there's no no reservoir bag. So these are just any oxygen that's overflowing is just going to flow out. If the patient draws more air in than the mask is providing, then they're going to pull in room air with it, which is fine because they probably don't need, if you got them on a simple mask, they probably do not need that much oxygen anyway. The flow rates are generally range from 6 to 10 liters per minute, and they provide 40 to 60% oxygen at the maximum rate, depending on your patient's respiratory rate and depth, of course. Delivery volumes beyond 10 liters does not enhance the oxygen concentration because there's nowhere, once you exhaust the mask of any oxygen that's in it, you're pulling in room air. So it's really not delivering any higher concentration if you go up to 15 liters, other than making more noise. These devices are rarely carried by EMS anymore, but you may see them on a transfer. This is a ER thing, or a small hospital where they might put them on. You may see them in nursing homes. Nursing homes like to put them on with a concentrator, is where I've seen them a lot. You'll see all kinds of things with these. I've seen people cut out the sides because the patient stated they couldn't breathe, so they cut the sides of the mask out and hooked it up to 5 liters per concentrator. So you'll see some interesting things out there. The partial rebreather mask that we've spoken about. Here, let me get caught up to where we are. Or no, we are caught up there. Is for patients requiring moderate to high concentrations when satisfactory clinical skills clinical results are not obtained with the simple mask. So the simple mask isn't providing what you want, or nasal cannula isn't providing what you want, and so you go to a partial non-rebreather. Basically, this is a non-rebreather mask with one valve missing. So half of your mask is open to air, the other side will close off and not allow as much room air in, and it has a reservoir bag. The minimal dilution occurs with inspiration of residual expired air along with the supplemental oxygen. The maximum flow rate on these is still, again, about 10 liters. These have replaced the simple face mask on EMS trucks, and if they're even there, other people or other masks that are being used, of course, is the non-rebreather. The non-rebreather has one-way ports on both sides where the valves are in place, but they also have an attached reservoir bag that hold oxygen ready to inhale. It provides the highest oxygen concentration at about 80% when set at 15 liters. So the range is 10 to 15 liters. You set your mask, and what you want is about 50% deflation of that reservoir bag. So when we put the patient on a non-rebreather, we want to make sure that reservoir bag is full before we put it to their face. So you reach in with a gloved finger and you cover the port, allowing oxygen into the mask, and you force it down to fill up that reservoir bag. And then you place it on the patient and you watch and you adjust your flow so that that bag does not completely deflate. If it completely deflates, then you're not providing enough oxygen for them. We only want about 50% deflation. They're commonly used in the EMS field, of course, for initial management of patients with high oxygen requirements. Any patient who requires a non-rebreather should be closely monitored for refractory hypoxemia that requires invasive or non-invasive positive pressure ventilation. So basically, you want to watch their respiratory status, and you want to watch their oxygenation to make sure that they are continuing to oxygenate. Make sure that there isn't something else going on. Of course, through our airway assessment, when we've listened, we've looked for blockages, we've looked for partial, we've checked blood pressure, checked heart rate. We know what the cause, we're honing in on the cause, right? So we're treating what we see and what we find, but we're reassessing. And if that patient has become tired or is wearing out or is entering respiratory failure, where the possibility of them needing positive pressure ventilations is coming about, we need to keep on top of that. So that's why that's why we continue to monitor our patients, not only O2 saturations, but end-tidal CO2 levels and their physical signs. Is their respirations, are they adequate? Are they deep enough? Is the rate appropriate? Is it too fast? Is it too slow?